Dear students, I have already told you about the diuretics and the physiology of the urine formation. Today I am going to revise it, and it will help you because once I talk on the, this YouTube, it will be more understanding. As you know, normal kidney function is extracellular fluid volume control. Number 2, it is electrolyte balance. Number 3, it is waste product excretion. And number 4 is drug and hormone elimination metabolism. Number 5 is blood pressure regulation. Number 6 is regulation of the hematocrit. Number 7 is regulation of the calcium phosphate balance, vitamin D3 metabolism. And now I have shown there 4-5 sites that you have to remember. And these 5 sites have been already enumerated, where it is function is at proximal convoluted tubule, and then loop of Henle, and then we have a different different sites again. We have renal corpuscles and the principal cells of the renal tubule. When we have, this is very important, this is the hormones are taking part at the collecting duct, and internal intercalated cells in late distal tubule. We have their bicarbonate also, urea also, and so this all, once you will complete this will come to your understanding. Now this is a nephron, basic kidney functional unit, which we call, and you have to remember that GFR, glomerular filtration rate, is 125 ml per minute. It is 180 liters per day, and out of this 99% is reabsorbed, and kidney uses active passive transport to achieve this. So there is a proximal convoluted tubule, there is a Bowman's capsule, then there is a descending loop of Henle, ascending loop of Henle, the collecting duct, and we have a distal convoluted tubule. This all, and the different mechanism of actions at which site the drugs are acting, so far as diuretics are concerned, and so far as the normal phenomena is concerned. When the disease, at that time the creatinine is also, kidney function tests are hampered. And now we have this glomerulus. Hydrostatic pressure in afferent arteriole is plus 75 millimeter mercury, and osmotic pressure, plasma albumin, is 25 millimeter mercury, and hydrostatic pressure is 5 millimeter mercury, and net filtering pressure is plus 45 millimeter mercury. Renal blood flow is 1300 ml per minute, and 1/4 of the cardiac output. And we have a glomerular filtration rate 125 ml per minute, that is 180 liters per day. And only 1 to 2 liters of the urine is excreted per day. About 99% of the filtrate is reabsorbed. So the kidney can be considered as a reabsorbing organ mainly. So here also we have to note down the conventional drugs and their reabsorption and their clearance. This all depends upon its half-life, upon its elimination, upon its volume of distribution, upon its so many things. And this is really a concept where you have to evolve this concept out of all drugs, and importantly those drugs which are diuretics. And now proximal convoluted tubule, we have site 1. Most of the filtered sodium chloride, about 65%, are actively absorbed here. And site 2, some sodium is reabsorbed in exchange for hydrogen ion under the effect of the carbonic anhydrase enzyme. So sodium is reabsorbed with its isosmotic water, obligatory water reabsorption. Filtrate is isochronic. Most of the filtered potassium, glucose, and amino acids are reabsorbed. Organic acids and the bases are also reabsorbed. In proximal convoluted tubule, there is uric acid, penicillin, diuretics, and the probenecid. These are the examples where you have to have this into concept, is secretion mechanism. And the most of the drug interaction is at this site. Now loop of Henle, we have descending loop of Henle where water is taken out. Then we have ascending loop of Henle where the sodium, potassium, and 2 chloride co-transport about 25 filtered sodium under the effect of the sodium potassium ATPase enzyme active. There is a passive transport chloride, and water impermeable, medulla is hydrostatic. So imbibe water from descending loop of Henle and distal convoluted tubule and collecting tubule, and then there is a counter current multiplier system. This is very important, this ascending and descending loop. Descending loop loses water due to the tonicity of interstitial fluid. So concentrate is the urine. So ascending loop often only loses salt. So this you have to remember. And then distal convoluted tubule site 4, early part of the distal convoluted tubule, cortical dilutive, increases that active reabsorption of about 10% of filtered sodium chloride. So late part of distal convoluted tubule, we have compensatory sodium reabsorption, limited capacity 3 to 5%. So site 5, sodium hydrogen exchange under the influence of the carbonic anhydrase, and site 5th is sodium potassium exchange under the effect of the aldosterone. This is the hormone part where it takes place. Late part of the distal convoluted tubule and collecting tubule. This is the reabsorption of water under the effect of the ADH, antidiuretic. There is a facultative water reabsorption. And then we have collecting duct, permeability water salt under the hormonal control. This is the active transport is there, and passive molecular movement is also there. So aldosterone, mineral corticosteroid increase sodium reabsorption, increase potassium excretion, antidiuretic hormone vasopressin, increase water permeability, increase urine osmolarity. So important site for potassium balance. So sodium transport lumen negative potential, higher urine flow washes potassium away, increase it and say concentration gradient. And then we have this all about the different sites, how it takes place, what are the different MSC, sodium, potassium, or carbonic anhydrase, and ADH, and we have a convoluted tubule. All these things, parts, you have to develop a MSC concept about this. Now we have a major function of the kidney, ultrafiltrate. It removes fluid volume from the circulating blood. Substances dissolved in the fluid are also removed. Fluid and electrolyte control 2 is it maintains correct balance of fluid and electrolytes within a normal range of excretion, secretion, and reabsorption. These are three processes. And acid-base functions. It maintains pH at normal range by directly excreting hydrogen ions and forming bicarbonate for buffering. Now this is the excretion of water product 4, direct removal of the metabolic waste products, like all drugs also contained in the glomerular filtrate. Blood pressure regulation 5th, it regulates the blood pressure by controlling circulating volume and renin excretion. Or RBCs production also is erythropoietin secretion by kidneys, stimulates bone marrow to produce RBCs. So regulation of calcium phosphate metabolism is a cell. Vitamin D activation is regulated by the kidney. And then we have clinical estimation of the renal function. Clinical examination, when we have to examine this, the palo, volume status, blood pressure, measurement, urine analysis. Clinical examination of renal function. Blood test, we can routine test, hemoglobin, electrolyte measurement, sodium, potassium, calcium, phosphorus, urea, creatinine normal range is 70 to 140. So these are the biochemicals which you have to do. And the serum creatinine GFR, it gives about the kidney function test, concentrate, muscle metabolite, proportional to muscle mass, high muscular young men, low conditions with muscle wasting, elderly, muscular dystrophy, anorexia, malignancy, 70 to 140 micromole per liter, this is normal range. And then we have a serum creatinine also 40 to 120 or we have we can 1 point up to 1.2 milligram per deciliter. Large muscle mass. This gives about how you have to interpret about this thing. Interfere with the urinary methyl dopa, levodopa, dexamethasone, cephalosporins. These are the biochemical interferences take place, and we get the wrong result. So inhibit tubular reabsorption, that is cimetidine, trimethoprim, aspirin, ketoacidosis. So these are increased. Decreased by reduced muscle mass, elderly, severe renal disease, increases secretion, cachexia, starvation when we have immobility and pregnancy. And this is the serum creatinine when we have GFR, and then we have a serum creatinine milligram per deciliter, how it becomes this curve. So this you have to remember anywhere. So serum urea, blood urea, nitrogen, how these factors can take place, and it varies with the dietary protein intake, reabsorption by the tubule, reabsorption varies with the urine flow, it decreases, it is independent of GFR, of volume, low urine flow rate. Factors increasing serum urea, we have high protein diet, we have hypercatabolic conditions, that is severe infection, burns, hyperthyroidism, gastrointestinal bleeding, we have muscle injury, drugs, that is glucocorticoid with catabolism, tetracycline, hypovolemia, factors increasing serum urea, we have malnutrition, liver disease. Now other biochemical abnormalities, like we have to raise serum potassium, hyperkalemia 3.5 to 5, and hyperkalemia develops when serum potassium is more than 7 millimole per liter. Life-threatening, is very risky. Raised serum phosphate 0.8 to 1.2. Chronic renal failure leads to hyperphosphatemia. Decreased serum calcium, we have 2.2 to 2.6. And then we have clinical assessments. This is all about the clinic. Now the nephron electrolyte handling. So sodium, potassium at the distal convoluted tubule, I mean to say this is the proximal convoluted sodium and potassium reabsorption takes place 60%. And sodium, potassium chloride, and we have Bartter syndrome. It is called as the bumetanide sensitive. This is one of the diuretics where this is sensitive. And we have 36% of this 30% of this reabsorption takes place at the ascending, and we have thiazide sensitive, that is the Gitelman syndrome, that is sodium chloride at that distal convoluted tubule. Then we have only 2% at sodium, potassium, and hydrogen Liddle syndrome, that is a pseudo hypoaldosteronism type 2. This is amiloride sensitive. So these sensitivity, we have 3, I would say, syndromes that you have to remember. And then we have diuretics. Now, this is the main diuretics drugs that increase the volume of the urine, increase water and solute. So then we can divide it into 2 parts: extrarenal, prerenal. Water and ethyl alcohol decrease release of the ADH, decrease facultative water reabsorption. So digital is only in case of the heart failure. It is the positive inotropic when the cardiac output increases and renal blood flow increases. So albumin only in case of hypoalbuminuria, restores osmotic pressure of plasma, increases blood volume, increases renal blood flow. Dobutamine is increased cardiac output and increases dopamine, cardiac output and renal volume, I would say increase the renal blood flow. So methylxanthine or theophylline also increases the cardiac output and renal volume and increase the renal blood flow plus renal effect. So in the renal we have natriuretic, saliuretic, osmotic diuretic. Number 2 is mannitol, and number 3 is acidifying diuretic, that is ammonium chloride. So this is about the diuretics, how you can differentiate. Now the osmotic diuretics, main example is the mannitol. It is filtered at the glomerulus but not reabsorbed. Increase urine osmolality, decrease water reabsorption, only diuretic acting outside nephron lumen. Given IV orally, osmotic diarrhea. Uses treatment of renal failure. Reduces intracranial pressure, intraocular pressure, but not a renal mechanism. It is not a renal mechanism. There is no renal, this is all due to the physical characteristics. So natriuretic and saliuretic, they decrease the sodium reabsorption from the nephron, increase sodium oxygen naturally in urine with this isosmotic obligatory water and volume of urine. High efficacy, high sealing loop diuretics. So these are 3 curves, these are low, moderate and high response. So high sealing diuretics and loop diuretics, they act mainly on the medullary part of the thick ascending loop of Henle. And examples are furosemide and ethacranic acid. And moderate efficacy diuretics, they act mainly on the cortical diluting segment. Examples are thiazide diuretics and thiazide analogs. Low efficacy diuretics are carbonic anhydrase and acetazolamide, potassium retaining, sparing or conserving diuretics, aldosterone antagonist, that is spironolactone, non-aldosterone antagonist, that is trimethoprim and amiloride. So you have to have the 3 types so far as the response is concerned. They are high, they are moderate, they are low when the this optimum response is concerned. Now this is all about the cortex and the hyperosmolar medulla, and then we have shown different types of loop diuretics, how they act, and there are 3 mechanisms: thiazide diuretics and spironolactone, amilorides, potassium retaining, and we have thiazide diuretics where there is a calcium is sodium and potassium is coming out. So this is the mechanism. This you have to sketch out the diagram, and then from the diagram you will come to know that where is the mechanism of action taking place at which part. And now this is also the osmotic diuretics where they act, and proximal convoluted tubule, what are the drugs which are acting carbonic anhydrase or the drugs, and thick ascending loop of Henle, we have loop diuretics, and distal convoluted tubule, we have the thiazides, and the collecting duct, we have aldosterone and all these hormonal, controlling diuretics. Now we have diuretic general consideration. All except osmotic diuretics act from inside lumen. Patterns of electrolyte excretion varies with class. Maximal response depends on site of action. Effects can be additive or synergistic. We can if we'll give the two diuretics, naturally they are synergistic or they are additive. So you have to find out these things. And now we have carbonic anhydrase inhibitors. Estrazolamide can trigger metabolic acidosis, not in use in diuretic anymore. Primary indication is glaucoma, prevents production of the aqueous humor. Dorzolamide is a calcium inhibitor or sulfonamide like and cross allergenic with antibiotics. So sulfonamide is type of drugs RA, and we have two drugs, estrazolamide and dorzolamide. So this is at the. Now we have pharmacodynamics, antidiuretic hormone. Only in nephrogenic diabetes insipidus we have to use, insensitive to ADH. May be due to decrease of the GFR, glomerular filtration. So hyperglycemia, we have open potassium channels, and hyperpolarization, like there is insulin release, and hyperlipidemia, increased blood cholesterol, and triglycerides, and we have hyperuricemia, decreased uric acid excretion via competition and in the proximal conductivity. This is the thermodynamic part, and that's why we have to see this can be taken as a side effect. And for antihypertensive effect, thiazides are effective antihypertensive, even subdiuretic doses, because mainly due to direct arteriolar this thing. So potassium channels opener, this hyperpolarization, diazoxide, thiazide, non-diuretic, but direct arterial they act. So there is a depletion of sodium and water from the arterial wall, decreased edema, and decreased pressure effect of noradrenaline and angiotensin. So prostaglandin may play a role here. NSAIDs and antihypertensive effect of thiazides. Diuretics decrease the blood volume, and temporal effect is not essential. So this is, you have to take what is the mechanism of action of as antihypertensive. So therapeutic use of thiazides, we have edema, cardiac, hepatic or renal. Thiazides are useful in congestive heart failure due to diuresis, decreased blood volume, decreased VR, and decreased edema and decreased preload. So arterial volume dilation is decreased total peripheral resistance and decrease afterload. So mild to moderate hypertension we can give, useful even in subtherapeutic diuretic doses. Direct vasodilation and decreased blood volume. Antagonizing edema induced by other vasodilators, that is hydralazine. Nephrogenic diabetes insipidus, premenstrual syndrome we can give, and premenstrual migraine. Idiopathic hypercalciuria and renal calcium calculi stones useful in hypocalcemia and osteoporosis. Now, pharmacodynamic diuretic effect we have to consider some thiazides, that is the chlorothiazide. They are weak decreasing of the carbonic anhydrase by their sulfonamide radical. Not essential for the diuretic effect. So fourth is excess sodium chloride will reach the late part of the distal conductivity, where part of the sodium is reabsorbed in exchange for potassium mainly and some hydrogen. The remaining sodium will be excreted in urine, and with it is isoosmotic water. Thiazides decrease renal blood flow, decrease GFR, they not indicate in renal insufficiency. Thiazides lose their diuretic effect when GFR is less than 20 ml. So we cannot give thiazides when we have a GFR less than 20 ml per minute. So hypokalemia adverse effect worsens digitalis liver and kidney insufficiency. Hypokalemia can be avoided. So hypokalemia by digoxin, hypokalemia by thiazides, we have a synergistic side effects. We have a synergistic hypokalemia and intermittent use of least effect dose of the diuretic. Fruit juice, potassium supplementation, also less irritation tablets. Add potassium retaining diuretics. We can use this diuretic along with the spironolactone because hyponatremia, hydrochloric alkalosis, hypomagnesemia, hypovolemia. These are the advantages of the spironolactone over here. And then hypokalemia diuretics increase sodium in distal convoluted tubule and increase sodium potassium in the exchange. So thiazides and loop diuretics, what is the difference? So it inhibits sodium chloride thiazides, it inhibits sodium potassium chloride, I would say reabsorber. So this is called as this is the early portion in the distal convoluted, but this is the co-transport in thick ascending part of the loop. So you have to make the differentiation. So it is less effective, it is potent. It is delayed, having only 1 hour effect. It is rapid, 20 minutes. That's why it's called the loop diuretic, is the immediate. And longer half-life, it is short duration. It has got no, I would say, GFR. It increased GFR, acted by GFR when it is less than 20 ml. It increased the response. So arteriodilator, it is no arteriodilator. It is the arteriodilator which has that. So you have to make the difference. What are the differences between thiazide and loop diuretics? And then thiazide, it increases serum calcium, it decreases sodium calcium. What is the difference? This is the thiazide and loop diuretics. It decreases the potassium, magnesium, sodium and potency, and it is more, I would say, like loop diuretic. It increases glucose, uric acid, lipid. So thiazide is produced, I would say this glucose, I would say it produces like glucosuria. So uric acid, so it produces like that. It is more. And then we have autotoxin, nephrotoxin. It is hypovolemia. It is hypovolemia. Uses this hypertension. We can have heart failure, hypocalcemia, idiopathic hypercalciuria, diabetic insipidus. This is the thiazides. This is the heart failure, renal failure, hypocalcemia, hypertension, and tolerance, and we have renal impairment. So hydrochlorothiazide and chlorothalidone, which is a long-acting, and indapamide, and there is a 2 to 4 hours duration. Or furosemide, bumetanide, ethacranic acid, indocranic acid, and uricosuric. So these are the pharmacology. Now, ceiling doses of IV and loop diuretics we can use. Furosemide, bumetanide, torsemide, we have given the, I would say, 3, drugs. And the cirrhosis we can give furosemide 40 to 80 milligram, and in heart failure 40 to 80 milligram, and in nephrotic syndrome 80 to 120 milligram, and ARF, CRF, AFR and CRF moderate 80 to 160, and ARF and CRF severe we can lead to 160 to 200 milligram. So since the bumetanide, it is 1 to 2, 1 to 2, 3, 4 to 8, and 8 to 10. And torsemide we have 10 to 20, 10 to 20, 10 to 20 to 50, 20 to 50, and 50 to 100. So protein binding increases ceiling dose, and impaired delivery increasing ceiling dose. So you have protein binding increase the ceiling dose, and impaired delivery increases ceiling dose. So this is what we have for ceiling dose effect. It's called a ceiling dose effect. What is the dose range in different different pathophysiological conditions. Now we have another slide that gives the importance of interaction. So NSAID salt decreases decongestants and probenecid. So this is the diminished diuretic response once we have these drugs. So if we cannot use NSAIDs and decongestants and probenecid, this is the interaction. So we cannot get the target response. ACE inhibitors, beta blockers, potassium supplementation, potassium sparing diuretics, heparin, also they cause hyperkalemia. So if you give the ACEs, if you give the beta blockers, if you give the potassium supplementation, if you give the potassium sparing diuretics and or heparin, they are hyperkalemic induced by potassium sparing diuretics. And autotoxic drugs, they also enhance autotoxic like loop diuretics. So autotoxic drugs we have it synergizes with the these diuretics. Now we have ARF, CRF, these are the different conditions we can give, and nephrotic syndrome, and congestive heart failure, and cirrhosis, and mild. This is the schedule, how we have to correlate with the creatine clearance. You go through this slide, intricately. And this is the world diuretic help these appreciably. So result is dietary protein deficiency, hypoalbuminuria, and insufficiency plasma. One oncotic pressure can vary from stable to extreme. So oncotic pressure is proteins. When you have good proteins, so there's a protein good that produces oncotic pressure can vary from subtle to extreme. So these are this is the message you have to give. And now hypokalemia, low potassium levels. Major problem with low dietary thiazides is because of the hypokalemia. Increased sodium chloride passed on the collecting duct, increased transport across principal cell. So increased lumen, versus potential lead to potassium loss. Increased volume of urine increases flushing of the potassium. So we have to see the hypokalemia is the main and the major side effect of the diuretics. And now potassium sparing diuretics, hyperkalemia, acts on distal convoluted increased exchange diuretic combination with thiazides. We have to, make a combination therapy with the potassium, thiazides plus potassium sparing. Precautions in important and added ACEs. Classified into aldosterone antagonists, we have spironolactone. Delayed onset is 2 to 3 days. Used only in presence of the hyperaldosteronemia. There is heart failure, hepatic failure. These are called the hyperaldosteronemia. So these conditions we can, give this supplementation. Side effects is gynecomastia. So spironolactone have a gynecomastia. In male, change of voice and irregular menses. Female, antagonizes digitalis and carbenoxolone. So particularly digitalis. Now potassium sparing, this all general mechanism, decrease transport, principal cell, sodium movement, decrease negative lumen potential. So example is spironolactone, amiloride and triamterene. This is the, examples of the potassium sparing diuretics. Now sodium channel blockers, a rapid onset, not dependent on aldosterone. Decreased calcium, hydrogen in urine, usually used in combination with the hypokalemic diuretics. This triamterene, urocorticoid, not used in hepatic impairment or renal stone. We cannot give the triamterene in when we have a hepatic impairment or renal stone. So amiloride and these things we have to make sure. And indication for potassium sparing, what are the indications when we have to give the potassium sparing? Primary hyperaldosteronism, yes, or that secondary to various other causes, like we have the congestive heart failure. Can be effective in edema or ascites from hepatic disease in some patients. However, ascites with advanced cirrhosis is not easily treated. Available in combination with the potassium sparing diuretics for opposing counteracting hyperkalemic and hypokalemic side effects. So this is the aldosterone excess might also have direct unexplained pathogenic effect on heart, speculative. So eplerenone is a newer aldosterone receptor antagonist, good for congestive heart failure and improvement in survival after MI. So eplerenone is a drug which is aldosterone receptor antagonist. It is good for congestive heart failure and improves the survival after myocardial infarction. Now volume signals, natriuretic peptides and antidiuretic hormone. Natriuretic peptides are covered elsewhere, CTX. Nasterides is a recombinant NP approved for decompensated congestive heart failure. Antidiuretic hormone or vasopressin is secreted by the hypothalamus, that you know, in response to volume depletion or increases osmolality. ADH causes increased CMP. So this is a secondary messenger, and insertion of the aquaporine water channels into lumen membrane. This permits outflow of water down osmolar gradient into the interstitium and venous return. So this is the drug which is active through the secondary messenger. So vasopressin, ADH and down desmopressin. That is I have already covered in the ADH, but you can also write over here. ADH normally increases CD permeability to water but not sodium, permitting water outflow driven by transepithelial osmotic driving force, 200 millimolar outside the tubule. The corticomedullary osmolar gradient is driven by the sodium potassium 2 chloride to transport in ascending limb and counter current exchange. Failure to secrete vasopressin from pituitary prevents water reabsorption and causes large volume of dilute urine. So another analog is desmopressin, is analog of ADH and ADH receptor agonist, causing antidiuresis or decreased urine flow. So lithium is a psychiatric practice, causes large diuresis. So once we give the lithium, there's a diuresis, almost 1 liter per day, Excess dilute urine in CMP related mechanism. It has got the same mechanism as I will say vasopressin, lithium. So lithium is very important over here, and lithium and diuretics should not be given like furosemide because lithium toxicity is there. There is a drug interaction. So independent study example of the use of diuretics with other drugs. Diuretics are widely used with or without glomerular. Good evidence for benefits versus risk. Some say they are overprescribed. However, in controlled trials, side effects are being found acceptable. That is moderate potassium abnormalities. So there is a study, NHLBI website provides summary of the sound medical practice. So this is the evidence based you can go. Here and in your text, several of the conditions for diuretics use are summarized. There are many others. Essential hypertension, various causes, heart failure, nephrotic syndrome, edema and ascites of cirrhosis, brain edema. So we can give these drugs. Now this is all about the mannitol, where it clinical use and side effects. Mannitol, we have increased intraocular pressure. We can give an intraocular pressure and hypernatremia. And furosemide, bumetanide, torsemide and ethacranic acid, these are the loop diuretics. What are the side effects? And like thiazides, we have the hydrochlorothiazide, hydrofluorothiazide, chlorothiazidone, and benfluoramethazole, polythiazole, and metalozone and indapamide. What are the different, indications and what are the contraindications? Spironolactone, epinephrine, I have told you is in CHF. We give amiloride, trimethoprim. What are different drugs? What is the clinical use? What is side effect? This nutshell, what you have gone through. And now same is the case with the drugs, different antihypertensive drugs where there is a combination and clinical use, side effects and interactions you have to give. What are the different ACIs and how the combination takes place. That you have already gone through the ACIs. Now we have normal glucose homeostasis, how it can be maintained, and glucose input and glucose output, and how net balance is there, because we know in the urine we cannot pass in the normal phenomena this glucose because we have a TM threshold level. Now existing novel mechanisms to reduce hyperglycemia in type 2 diabetes, insulin dependent and insulin independent. We have now another analog, and insulin maintained, that called the SGLT2. Glucose excretion caloric loss is there. So glucose utilization we can give now. Then sodium glucose transport mechanism. That is the newer novel drug which is used in diabetes that you have gone through. And this is the site, SGLT1, SGLT2. I told you where this site is SGLT1. It is where it is SGLT1 and SGLT2, where this kidney can take on kidney. There is a mechanism of action. Site is intestine, kidney, SGLT1, and kidney is SGLT2. So it is not in the intestine. So the sugar specificity, we have glucose or galactose and glucose. You have to mention this thing because you should know glucose affinity is high in case of SGLT2, but it is in low SGLT2. So it is GI transport capacity is low, but it is very, very high. So role dietary absorption of glucose and galactose, renal glucose reabsorption, So this is the difference between the newer analogs for the diabetes mellitus we give, and now the novel drugs which are called as SGLT1 or SGLT2. These are the analogs now in that. So dapagliflozin, a novel insulin independent approach to remove excess glucose. So this is also one of the newer drugs that is called as the dapagliflozin. It inhibits at SGLT2, so it keeps this glucose level is filtration takes place when there is more glucose through the urine. So how it can be glucose can be get rid of from the body. So treatment with SGLT2 inhibitor, clinical benefits in type 2 diabetes, this will come to know. So this is the sustained glucose lowering, and this is the osmotic diuretic also. Initial weight loss is given, and insulin independent mechanism and loss of excess calories to SGLT2. And then we have nephrotoxic drugs. What are the nephrotoxic drugs? You have to remember, because at the end of the day, how you will come to know that the interaction is very important, and what are the nephrotoxic drugs, because you are dealing with the nephrons, and dose-dependent toxicity is NSAIDs, influencing COX-2, including aminoglycosides, radio-opaque contrast material, these are the nephrotoxic drugs. And idiosyncratic renal damage also NSAIDs, penicillins, gold, penicillamine. So these are the drugs. At the quick session, you have to remember these drugs. And then NSAIDs, non-steroidal anti-inflammatory, commonly used, interfere with the prostaglandin production, disrupt regulation of the renal medullary blood flow, and salt-water balance. So prostaglandin is very important for reabsorption and all that. So chronic renal failure, habitual use, they will produce the chronic renal CRF. So exacerbated by other drugs, antihypertensives, ACIs, they can precipitate, they can potentiate. Topical radiological features when advanced. Then we have nephrotic syndrome, glomerular filtration injury, and proteinuria, that is lead. Nephrotic syndrome, glomerular filtration injury, that is hematuria, that is amphetamine. Tubular necrosis, we have lead, coumarin, and mercury. Obstructive uropathies, intrarenal toxicant crystal disposition, there is sulfonamide. Extrarenal, due to the retroperitoneal fibrosis, we have methotrexate. So these are the examples. You have to remember what are the nephrotoxic drugs. And diabetic nephropathy is pre-glomerular arterial dilatation. It is increased, post-glomerular arterial constriction. So a result of these hemodynamic changes is increased pressure and flow in the glomerulus. So hyperfiltration is there. So this is the summary of the ACIs and the ARBs in the CKD that you have gone through. What are the, GFR in the kidney stages, different development, how acute and chronic renal failure takes place when GFR you take into consideration, and examples of the phosphate binding medications. And this is all about, you have to go through different treatments, adult dose. And thank you very much. I hope you will have understood. If any question and query, you can ask.